Hello and welcome to the Echo by Web YouTube channel. It is a channel for professionals, cardiologists and sonographers, but not only, dedicated to the world of echocardiography. The aim of this channel is to provide the basic physiopathology and methodology which are necessary to understand how to perform and interpret a complete echocardiographic examination today. This channel will deal with many of the topics we all have to engage with in daily practice: valvulopathies, cardiomyopathies, systolic and diastolic function, and also new technologies, like left ventricular systolic strain analysis of the left ventricle. My name is Paolo Barbier. I am broadcasting from Italy. I am a cardiologist with a special interest in echocardiography, and I will guide you through talks and clinical cases from my clinical experience, addressing a wide range of echocardiography topics. My imaging, the images that you will see in my channel, are based on patients studied in Italy and in Northeast China, where I have worked for about 5 years. Echo by Web is also a website, echobyweb.com, where you will find much of the materials I will present you in this channel. So let's have a look. The topic of the present talk, which spans over 2 videos, is the echocardiographic analysis of left ventricular volumes and mass in the real world, and this is a basic approach. In this talk, we're going to review how to measure left ventricular mass index and the relative wall thickness index by looking at MO measurements, 2D and 3D measurements. Then we will move on to how to measure left ventricular volumes, and we will see the very important issue of the left ventricular geometry and how to respect it. And then we will see pitfalls that occur when LV geometry is incorrect. And at the end, a quick look at the 3D exam concerning volumes and ejection fraction. This is video number 2, from relative wall thickness index measurements to 3D LV volumes. And now let's come to the calculation of the relative wall thickness index, H on R. This index uses the same measures that we have used for the mass index, so the thickness of the walls and the diameter of the cavity. This index was introduced by Rychek in 1982, and this is the formula. At the numerator, you sum up the thickness of the posterior wall and of the septum. At the denominator, you have the diameter of the cavity. This is one formula, the one that I prefer. The other one, the original one, at the numerator, you don't have the septum. You multiply by 2 the posterior wall. In fact, I prefer to use this one because it's more democratic. It considers at least 2 walls. Down here, you have the normal range. And 0.42 is usually considered the cutoff between normal and abnormal. With M mode, you make the measurements with the ASIN standard method, leading edge to leading edge, as we said. But as I told you before, it's much preferable to use the direct 2D linear measurements on the 2D image. Anyhow, for the sake of history, this is the standard calculation with M mode you see here. So we are taking again the graph, the Cartesian graph, with on the horizontal axis the mass index, and on the vertical axis the relative wall thickness index with 4 sectors. Okay, the normal geometry sectors, we have seen this before, the concentric remodeling, the eccentric hypertrophy, and the concentric hypertrophy geometry. So we have M-mode examples for each, including the pitfalls. You can see here that the endocardium of the thickness of the interventricular septum has multiple lines in systole. So this is not very accurate in this measurement, also here. Whereas up here, for example, a concentric hypertrophy, we have a good linear echo. Anyhow, here you have the measurements, and up here you have the relative wall thickness index and the mass index. So in this patient here with a normal geometry, you have 0.42 for the relative wall thickness and 106 for mass. Up here, the patient with concentric remodeling has still a normal mass, the same mass as the patient down here, but has a high relative wall thickness index. The eccentric hypertrophy has a high mass index, 163, and a normal relative wall thickness. And you can see that both indices are increased in the concentric hypertrophy geometry. And in this slide you see for the four types of left ventricular geometry, the 2D imaging in short axis. So in A we have the normal geometry, in B the concentric remodeling, in C the eccentric hypertrophy, and in D we have concentric hypertrophy, okay, with the endocardium and the epicardium. And now let's look how to obtain the left ventricular volumes. The standard method is the 2D imaging with the Simpson disk summation formula, which is available on all echographic machines, old and new. The operator here must obtain a view which respects left ventricular geometry, we will see this in a minute, identify the endocardium of the left ventricle and perform the planimetry, we will also see this, and then also check the accuracy and reliability of the obtained measures and calculations before putting them in the report. The calculation of ejection fraction in this slide is shown down here. So you subtract the end systolic volume from the end diastolic volume and you normalize or divide by the end diastolic volume. Note that the formula can also be seen from a hemodynamic perspective as the normalization of stroke volume by left ventricular preload, because left ventricular preload is the end diastolic volume. This is a relatively simple operation. Take also into account that we always consider biplane volumes. So 4-chamber and 2-chamber. You should never calculate volumes and ejection fraction from only one chamber unless there is no other way of doing this. The advantages of the 2D method when you compare it to the M mode is that you correct for shape distortions, at least for most of them, and there are less geometrical assumptions. On the flip side, it is the most frequent error or pitfall is that the apex is frequently foreshortened with the consequences that we will see in a minute, and then you can have endocardial dropout. There is also the problem that we are blind to shape distortions which are not visualized in the 2 and the 4-chamber planes. So for example, anything that affects what is viewed in the 3-chamber, apical 3-chamber, that concerns the anterior septum and posterior wall is not included in the analysis. So if a patient has an aneurysm with dyskinesis of the posterior wall, then your ejection fraction will overestimate the real ejection fraction because it doesn't see the aneurysm. But still the main issue, that's why I put it in red here, is that this is to address the correct geometry of the left ventricle, the importance of recognizing a correct geometry, because the most common error generally in echocardiography, I think, is the incorrect representation of the left ventricular long axis and the apex, an error which in English is known as foreshortening of the left ventricular apex. This results in a calculation that can both over or underestimate both the end diastolic volume and systolic volume and the ejection fraction depending on the patient. The most popular method and the most used formula to calculate the volumes of the left heart chambers, left ventricle and left atrium is the disk summation method according to Simpson's rule. As you can see here on the left ventricle is divided into a number of cylindrical sections, these ones, of equal height, which are distributed along the major long axis in both the 4-chamber and 2-chamber view in diastole and in systole. The total volume is obtained because the machine calculates the volume from each cylinder and then adds them up to obtain the total volume. The disc summation formula builds on the tracing of the left ventricular endocardium in both the 4 and the 2 chamber views, apical views, to delimit the cavity of the left ventricle and calculate the long axis. So let's look how to perform the planimetry of the endocardiums. On the left here, we start by searching for the end diastolic frame onto the imaging by advancing the clip 1 frame at a time manually until we see the initial closing movement of the mitral valve. We usually look at the anterior leaflet, which is more visible. This initial movement indicates isovolumic contraction, so end diastole. And this is more reliable, this method, than looking at the QRS, the EKG, which sometimes is not always reliable. Once identified the end diastolic frame, we then trace the endocardium by starting either one of the 2 hinge points of the mitral annulus. I usually start here at the lateral, the base lateral wall, but you can start at the septum. You follow the endocardium, staying on the endocardial brightness, not inside, and you exclude the papillary muscles and anything that is inside the cavity as accurately as possible. You try to extrapolate when the endocardium is not clearly visible. It is essential to clearly observe the movement of the endocardium, and you can do this by advancing and going forwards and backwards manually on the clip, so that you can follow the movement on the endocardium, which is usually easy to do because the endocardium has a predictable movement from the outwards to inwards towards the geometrical center of the cavity. We then proceed to identify the end systolic frame, again by advancing 1 frame at a time, and end systole corresponds to the frame with the mitral leaflets closed immediately before the frame in which the first of the visualized segments begins to relax. That means to move outwards. And you can see this here. Contraction. There. At this point, you can see that it starts to relax. So this would be end systole. Let's see it once again. So you have closing and then it starts to relax. Go backwards. Okay, systole, mitral valve closes, then the endocardium moves inwards. Look at the base of the lateral wall. At this point here, it starts to relax. That's end systole. Now let's look together at some examples of the problem of the correct representation of left ventricular geometry. Look at these 2 apical 4-chamber views. Are they geometrically both correct? They're similar. In both, the long axis is much longer than the short axis, as expected. The myocardial segments don't appear distorted. The 2 apical segments approach facing each other, the septal and the lateral, as they should in systole. The apex is a sharp angle. As a matter of fact, the image which is correct is this one on the right. Why? Because it has a longer long axis, 7.4 against 6.9. Now, this 9 millimeter difference marks the point. In this patient, the left apical 4-chamber view on the left, which was obtained as recommended at calm end expiration, was foreshortened. In contrast, this one, which was obtained at the end of a calm inspiration, shows the correct geometry. In this patient, in fact, at the patient here with incorrect geometry at the end of expiration, the transducer is slightly shifted toward the apical segment of the anterior wall, which results in foreshortening of the LV apex, and the long axis is shortened. Whereas in this patient, at the end of inspiration, what happens is that the left lung, instead of covering the left ventricle, shifts it so that it can actually be seen better. The only way, in fact, to determine if we are obtaining a correct geometry in our patient is to explore different apical views. There's no other way. Both by moving the transducer and by varying, we must have a collaborating patient, by varying the respiration phase. So by exploring the left ventricle at the end of inspiration and at the end of expiration, or even midway, until we obtain the longest long axis of the left ventricle. As I said, in many patients, which may sound counterintuitive, but during inspiration the lungs does not cover the left ventricle or the apex, but shifts it and makes it more clearly visible. In this case, usually you have to shift the transducer more immediately. This procedure is absolutely essential in all patients to avoid obtaining incorrect volumes and ejection fraction. And this method of proceeding distinguishes the operator who works with quality. Now, once we have obtained an apparently correct four-chamber view here on the left, it is important to compare it with the corresponding two-chamber view here on the right, obtained usually immediately afterward. The echocardiographic machine provides us with a wealth of information resulting from our measurements, and we must learn to interpret them all. We have areas, we have a long axis, we have volumes in end diastole, in end systole, and then the corresponding stroke volumes, and finally biplane volumes and ejection fraction. You see, at the end of the procedure here, when we finish the two-chamber view, the machine provides us also with biplane volumes down here, and diastolic biplane and systolic biplane, and the ejection fraction. You can also have stroke volume, as we said. Now, during the measurement phase, we are interested in the two long axes, the four and two-chamber view. You can see here the long axis in the four-chamber view is 8.1 centimeters. In the two-chamber view, it's 7.7, so a minor difference between the two. While the four-chamber, the long axis, is subject to foreshortening due to the incorrect transducer position we have just seen on the apex, the two-chamber view does usually not have this problem. Here the transducer, here is the transducer, so you see in the two-chamber view the transducer usually is on the anterior wall, but there is no problem in seeing correctly the long axis, whereas the transducer in the four-chamber view is on the apex, looks at the apex. So before concluding how the volumes in the ejection fraction is in the patient, we must verify that the difference between the two four-chamber and two-chamber long axis is minimal. It's better if it's less 5 millimeters or less than 5 millimeters. Okay, another example. This is a real-life example. We have two apical four-chamber recordings. Which one is correct, geometrically speaking? Well, this is the same patient. It's being recorded 1 minute apart to reproduce what unfortunately had happened in real life during patient follow-up after an aortic valve, positioning of an aortic valve mechanical prosthesis. Here too, this recording on the left, which is what happened in real life, appears correct, because the long axis you see is is almost a double of the short axis. But there is instead a marked foreshortening of the long axis in this four-chamber. If you compare it with this one, which is the correct one. What makes us immediately decide which is the best of these two views, which is the geometric difference that we can see immediately, qualitatively, that makes us decide which is correct and which is not? Look at the shapes of the total cardiac area, two ventricles and two atria. On the left here, the incorrect image, we have a circle, a soccer ball. On the right, the correct geometry, it's an oval, a rugby ball. This is what lets us immediately recognize whether the imaging that we have of the cardiac area, total cardiac area, is correct or not. So if it's a circle, we must correct it immediately. This works both in normal ventricles and in dilated cardiomyopathies, even in greatly dilated cardiomyopathies. Look at the patient we saw a few slides before, the very dilated, a little bit less than 500 milliliters in diastolic volume, so very dilated, and if you see the total cardiac area is still an oval, a rugby ball. Look at the difference in the long axis. This is the same patient we have just seen. The long axis between the two views, the incorrect for chamber, foreshortened, and the correct for chamber. The long axis in the foreshortened chamber is 9.6 centimeters. In the correct geometry, it's 11.3 centimeters. It's almost 2 centimeters difference, a very big difference for a long axis. And you can see that this translates in a huge difference in this specific patient of ejection fraction. So the incorrect position in the foreshortening gave us a normal ejection fraction, whereas the correct geometry gave us a moderate reduction of left ventricular biplane volume. I was saying that this was a real-life case. In fact, the patient, after the surgery, was followed up for several years, always with the wrong geometry recorded. So the attending physician was convinced that he had a normal ejection fraction. Finally, after a few years, an operator with a better understanding of left ventricular geometry noticed it, and so the ejection fraction was noted as moderately reduced, was placed on guideline-directed medical therapy, and after 6 months he partially recovered systolic function. In my opinion, this is the main problem with routine echocardiography today, both in community hospital and tertiary care centers. This error is quite common, and as you can see here, it may have a significant impact on patients. It may even modify outcomes. Now, this problem of the incorrect positioning of the transducer is caused by the tendency of many operators, especially young operators, of putting a transducer immediately at the beginning of the apical views, immediately below or very near to the mammary areola, as seen here. And this often is an incorrect position, because the only case in which this position is correct is in young people which have a ventricle which is direction like north to south. The majority of patients have a ventricle which is oblique here on the diaphragm. So the best way to prevent the incorrect positioning of the transducer, which is difficult to correct at the beginning, because if you put this transducer the incorrect position but you see well the endocardiums, then you tend not to shift from there anymore because you are afraid of losing the endocardium. So as I said, a simple way of correcting this whole problem is to start the apical views by putting the position of the transducer away from the anterior wall at the midline, at the anterior, at the mid-axillary or anterior line. And then from there, if you don't see the heart, shifting slowly medially. As I mentioned, it is essential to manage breathing while you try different positions of the transducer until the correct view is obtained. This is very important. It's much more important than seeing well the endocardium. And another real-life example, in the upper right image, an incorrect view with marked foreshortening of the apex, which produced a marked reduction of ejection fraction. As a consequence, the patient was admitted to perform coronary angiography because he had some kind of chest pain. The real ejection fraction, as you can see, was 53%, and the correct geometry is shown here on the left. You can see the difference, the oval global total cardiac area and the circular total global area here. Another real-life example, look at the different cardiac geometries between this incorrect apical four-chamber view, soccer ball, total cardiac area is a circle, and this correct one with a total cardiac area with correct geometry of rugby ball, oval. This is a 43-year-old male patient with coronary artery disease. He had the previous anterior myocardial infarction and then underwent coronary artery bypass surgery. This baseline exam with incorrect geometry gave a normal 55% ejection fraction, a normal volume. The following exam with the correct geometry gave much bigger volume, even though the ejection fraction was practically the same. But the clinical impact here was not much on the ejection fraction, but the fact that the baseline examination here with the incorrect geometry gave normal wall motion, whereas the true wall motion was this one. So he had hypoakinesis of the inferior septum and hypokinesis of the inferior wall. In this other patient with a previous mitral valvuloplasty, surgical valvuloplasty, as you can see here, the postoperative exam suggests an ejection fraction, a normal ejection fraction of 59%, not significantly different from the preoperative 62%. After 1 year, the ejection fraction appears to have dramatically reduced, 37%, a severe reduction. However, re-examining the images from previous year clearly showed that the previous year there was a marked foreshortening of the left ventricle. You can see the total area here, again a circle. Whereas after a year, this is an exam with a correct geometry with a global total area, which is an oval. Again, this error significantly impacted on the patient because adequate medical therapy for the reduced ejection fraction, which was reduction, post-operative reduction, was delayed for at least a year. Unfortunately, as I said, this is quite common in clinical practice. And I have a question for you who are looking at this video now. How many of you that are looking at this data have been taught about this problem during medical training? Obviously, an incorrect geometry will also influence all derived analysis, just as this one. This is left ventricular longitudinal strain. In this example, in this case, it's not as much as the mean strain value that is altered, but rather the evaluation of the segmental curves, so the regional strain function. So global strain in the incorrect geometry, the foreshortening that you see here is minus 14.6%, whereas global longitudinal strain of the correct geometry from the same patient is minus 15.3. So that does not make a clinically significant difference. But look at the dramatic difference between, for example, here in the four-chamber view, the segmental lines, the segmental strain of the 6 walls here and here. There is a dramatic difference. This geometry issue stresses 2 points. First, left ventricular foreshortening makes the exam inaccurate, since left ventricular volumes, systolic function, the ejection fraction, and the strain, and also the evaluation of valvular regurgitations are all affected. And 2, the operator that is not aware of this issue and produces incorrect images and incorrect volume and ejection fraction, as we have seen, is an unreliable operator, which makes the whole exam unreliable. And finally, there is plan B. When plan A, the apical views are of no use. What if there is no way to acquire the apical views like in this patient who had a previous left ventricular apical aneurysmectomy and positioning of an apical patch? This image on the upper left. You see the very bright echoes from the dacron patch, which in this setting the patch decreases dramatically the ultrasound penetration, so you don't see the rest of the ventricle, and we don't even see the mitral valve. So no endocardiums, no volumes, no ejection fraction. And down here you see another way of positioning your transducer, but still you can't really see anything of the endocardium. Well, in this case, you can position yourself in a subcostal view. Okay, in the subcostal view, you have a 4-chamber. In this case, was lucky, you could see very well the endocardium, so why not do the 4-chamber volume and ejection fraction here? So you will only have a monoplane ejection fraction and volumes, but you know, a monoplane ejection fraction in this patient is better than no ejection fraction at all. And finally, for those who have at their disposal, the lucky ones, a 3D probe, there's the 3D option, which is independent of any geometric assumption and provides more accurate volumes and ejection fraction, or of course after the necessary learning curve. And however, remember that the baseline 2D imaging must be optimal because there is the decrease in quality of the imaging when you switch on the 3D probe. There are different commercial software and probes and calculation algorithms available, constantly improving. The one you see here at this point is quite old. The analysis still requires the intervention of the operator for quality control. This is very important. Note in this case, this apparent dyskinesis here where the papillary muscle is in this mid-lateral segment due to the software failure to recognize the endocardium there. So in this case, there is no need for the manual intervention of the operator. Again, as we have seen before talking about the mass, you have orthogonal 2D views, and you have here orthogonal 2D views, the 4-chamber view and the 90 degrees 3-chamber view, and you have a series also of short axes, so you can control and you can check if the endocardium has been adequately placed. And then you have all the segmental lines, and here you can see very nicely the volume curve during the cardiac cycle. So in the end, I would like to remind you again about the website echobyweb.com. This is the QR code to access it. In here you will find a lot of materials for cardiologists and sonographers, a lot of what I've said also in this talk. And this is the end of the talk on the echocardiographic analysis of left ventricular volume and mass. This was the second video, and see you in the next video.